Hello and welcome to the chapters on men's health. Let's go ahead and get started here. Again, we're starting then on chapter 52. We're going to do the review of the androgens like Laney's likes to do here. And we start off speaking about testosterone. Remember that testosterone is present in both male and females, although we think of it mainly, obviously, with male health. When we talk about the biosynthesis and secretion in males, testosterone is made by the Leydig cells of the testes, and the synthesis is promoted by two hormones of the anterior pituitary, which is the follicle-stimulating hormone, and luteinizing hormone. And if you've listened to the women's health lectures, you remember that we spoke of these as well when we talked about the female menstrual cycle. Production of the testosterone is regulated by the negative feedback control, so the rising plasma levels of testosterone act on the pituitary to suppress further release of FSH and LH, thereby decreasing the stimulus for further testosterone. So it's a negative feedback loop. So as the testosterone level rises, you'll see that the body then tells the pituitary to suppress the amount of FSH and LH, and thereby if you were to increase the FSH and LH production or release by the pituitary, then you'd see a decrease in the amount of plasma testosterone. It does note here that some of the testosterone is present in plasma cell, is present produced by adrenal glands, but the most of that is a very, very minimal amount, and so most of what we get is testicular in origin. Testosterone production does change over time, and so obviously your peak production occurs around the age of 17. Production then remains steady until about the age of 30 or 40, and then it does start to slowly decline just naturally. But by the time the man reaches 80 years of age, testosterone production is only half of what it was in his youth. When we talk about the testosterone that's present in females, the pre-androgens, the precursor of testosterone, is secreted by the adrenal cortex and the ovaries. Conversion into testosterone does take place in peripheral tissues. The total of the testosterone is 10 to 40 times less than the amount produced in men. So in the event of ovarian or adrenocorticoid pathology, such as cancers, secretion of androgens can greatly increase and may be sufficient to produce virilization. And at menopause, testosterone production decreases. So again, we're in the chapter regarding men's health, so we're going to focus mainly on the male physiology. Mechanism of action for testosterone. Again, it's similar to some of the other hormones we've talked about in that its target tissues are mediated by specific receptors located inside the cell cytoplasm. After binding of the testosterone to its receptor, the hormone receptor complex has to migrate into the cell nucleus before it can act on the DNA to promote synthesis of specific messenger RNA molecules. And then these in turn serve as templates for production of specific proteins, which then mediate testosterone effects. It does note that in some tissues, the prostate, seminal vesicles, and hair follicles, androgen receptors do not interact with testosterone itself. Rather, they interact with the dihydrotestosterone, which is a testosterone metabolite. So to break that down again, it is kind of similar to that of estrogen when we spoke of how it has to actually migrate into the cell, into the nucleus of the cell. So there's a couple of processes that have to happen in order for testosterone to do its function. So how does this affect, again, male sex characteristics? So physiologic and pharmacologic effects. Obviously, in puberty, testosterone is necessary for the pubertal transformation, right? So going from from childhood into pubertal adolescence, you need testosterone for the men. This increase in testosterone promotes the transformation that signal puberty in males, and under the influence of testosterone, the testes enlarge, after which the penis and scrotum then enlarge. You develop pubic and axillary hair. Hair on the trunk, arms, and legs starts to look like an adult pattern. The testosterone stimulates the growth of bone and skeletal muscles, causing height and weight to increase rapidly. These are when you'll have these young boys all of a sudden gain 3 or 4 inches in a summer. Testosterone also accelerates the epiphyseal closure, causing bone growth to cease within a few years. The larynx enlarges, thereby deepening the voice. Sebaceous glands increase in number, causing the skin to become oily, and you can get the acne if the glands become clogged and infected. And the final pubertal change is the beard development, and it takes several years for all of these changes to occur. Spermatogenesis. The androgens are necessary for production of sperm by the seminiferous tubules and for the maturation of sperm as they pass through the epididymis and vas deferens. So if you are low on testosterone or you have androgen deficiency, that can be what can result in sterility. I'm going to pass through the effects on the females. You guys can read that. Anabolic effects. The testosterone promotes growth of skeletal muscles. The testes of the adult males already produce enough testosterone to cause near maximal stimulation of the musculature. Therefore, the increment in muscle mass that can be achieved with exogenous androgens in the male is relatively small. And I put that in here because this is what we talk about with anabolic steroids, right? That sometimes young men or some young women think that if they can take an exogenous androgen, that they're going to get this huge increase, excuse me, and that is just simply not the case. Erythropoietic effects. So the testosterone promotes synthesis of erythropoietin, which is the hormone that acts on your bone marrow to increase production of erythrocytes. So this is erythropoietin is the drug that you can give like in chronic kidney disease to help treat anemia of chronic kidney disease, right? So this explains why men typically present with higher levels of your hemoglobin and hematocrit than women do. Because the testosterone together with the high level of testosterone in males will cause then that higher erythrocyte count because it promotes erythropoietin. When women are given testosterone, your hematocrit and hemoglobin levels will increase as well. This part here talks about clinical pharmacology of the androgens. The androgens usually fall into two basic groups. We talk about testosterone and the testosterone esters, and then the 17 alpha alkylated compounds, which are well known for their hepatotoxicity. So I highlighted table 52.1 just to kind of show that their table and how they say that here. But I like this paragraph here to help explain this further. When one is speaking of the testosterone-like compounds, it's traditional to distinguish between androgens and anabolic steroids, but for the purpose of this chapter, they do not make that distinction because it's now clear that the receptor type that mediates the androgenic actions of the androgens is the same receptor that mediates the anabolic actions of hormones. So consequently, it's not been possible to separate anabolic activity from androgenic activity. So virtually all anabolic hormones are also androgenic. I cannot say that word. Androgenic. Accordingly, rather than creating the two categories, androgens versus anabolic steroids, they group them together. So they refer to all testosterone-like drugs as androgens. There is obviously use for the androgen and testosterone medications. And so I did point this out here that the new labeling from 2018 from the FDA states that testosterone use is only for those patients with confirmed testosterone deficiency due to hypogonadism, and that they lowered or they emphasize that lower testosterone just straight up from aging does not meet the criteria for this. We'll talk a little bit more about that. So when we speak of the hypogonadism for men, hypogonadism is a condition in which the testes fail to produce adequate amounts of testosterone. So male hypogonadism may be hereditary or it can come from other causes, including pituitary failure, hypothalamic failure, and primary dysfunction of the testes. What they don't talk about here is also that there's proof now that we know that severe and uncontrolled sleep apnea can also cause hypogonadism, which I think is an interesting point I just wanted to throw out there. So replacement therapy in hypogonadism. So androgen replacement therapy is beneficial. So it can be beneficial when testicular failure occurs in adult males. but there are some studies that demonstrate that the treatment does restore libido. It can increase ejaculate volume and supports expression of secondary sex characteristics. However, treatment will not restore fertility. And that's a hard thing for men that are considered sterile because of hypogonadism, that even with exogenous testosterone, you would not fix their fertility. Table 52.2 here, I just wanted you to kind of pay more attention to some of these considerations there. Again, I would never ask you on a test to know the dosage of a medication, but as you can see, some of these have hepatotoxic effects. Some of them require weekly visits. Sometimes it's hard for these gels to attain a certain level. So these drugs do come with the positives and negatives, and they can be kind of difficult to manage to get the right effect of what you're looking for. I'm going to skip through the part about the puberty because that's not really the focus of our more adult topic here, but you're surely welcome to read on that. I did highlight here there is some evidence to suggest that testosterone therapy can be useful in menopausal women because it can help decrease the symptoms of fatigue or reduce libido or reduce genital sensitivity. And even though the North American Menopause Society recognizes this, today in the United States, testosterone is not approved for replacement in women, but they are using it in the United Kingdom. Cachexia is a wasting of the body associated with severe illness, and testosterone levels often decline in these patients. And so there is a small group of patients through which you could use testosterone therapy to help decrease this risk, such as an HIV or trauma. And it comes with its own black box warning there. I'm going to skip past the anemias and the transgender part now. But there's more to come on the transgender part if you'd like to be able to read through that in more detail. Again, of course, we have the Beers criteria that testosterone and the methyl testosterone are potentially inappropriate for elderly patients. When we talk about the adverse effects of testosterone therapy, right? Virilization is the most common complication of the androgen therapy. So when taken in high doses by women, we know that androgens can cause acne, deepening of the voice, proliferation of facial and body hair, and male pattern baldness, but it can increase the libido, clitoral enlargement, and menstrual irregularities. The clitoral growth, hair loss, and lowering of the voice may be irreversible. The masculinization can also occur if taken by children, and boys may experience growth of pubic hair, penile enlargement, and increased frequency of erections, and even priapism, which is the persistent erection, which can be dangerous. When we talk about the use of androgens as an adverse effect, hepatotoxicity should be something that's always in your mind because androgens can cause cholestatic hepatitis and other disorders of the liver, so you can see clinical jaundice, but it is rare. But patients that do receive any kind of testosterone or androgen therapy should undergo periodic testing of the liver. Androgens do not cause prostate cancer, but they can promote the growth of the cancer after it occurs. So androgens are contraindicated in men with prostate cancer. And that should be something in the back of your mind for monitoring if you're using androgen therapy in men. It can also have an adverse effect of edema, which can result from the retention of salt in water. It's a concern, obviously, for heart failure or could be predisposition to developing edema from other causes. You could treat with obviously stopping the therapy or giving a diuretic if needed. And of course, they have the potential for risk for thromboembolic events, and that they can be or these are thought to be related because of the erythropoietic effect. So they do have a safety alert now if you prescribe these. And I'm going to stop here and come back in part 2.